Okay, good morning, everybody. Welcome back to the San Donato Cath Lab. So I'm here with Oliver Stumper, our guest, with Mario Giordano, our fellow, our technicians and nurses that we are helping us. I will go to introduce our case. I will ask Andrea Andronache to introduce.
We are presenting the case of a 4-year-old girl who weighs 20 kilos. She was assessed for a cardiac murmur and that found the PDA. The child is asymptomatic and has a normal growth and development. The ECG is normal, and on the chest X-ray we found cardiomegaly and lung congestion. The echocardiogram showed the enlargement of the left cardiac chambers with normal contractility due to a large PDA shunt left to right. The maximum gradient across the PDA was 90 millimeters of mercury. The intent is to close the PDA with a device.
Okay, so we started the case. Please, Oliver, can you show what we have done until now?
No, I think we should see the angios. And yeah, I hope you can see it. This is basically a lateral angiogram with a pigtail marker points. And basically it's a fairly short ampulla projecting the middle bit or narrow bit, probably projecting onto the anterior border of trachea. Quite a big pulmonary artery dilated, but the pressure in the pulmonary artery was normal, as you can also assess from the echo. And then on the RAO view, next angio. Can we see the next? Oh yeah, there it is. So, I don't know, I mean, I personally don't think it's particularly useful, and I normally would just go lateral to orientate myself on the trachea, really. And yeah, basically, we've got a 6 French in the vein and a 5 French in the artery. And we should now basically cross the duct. Yeah, we had a discussion as to which device to take. The measurements, I think, was 5 millimeter narrow.
Yes, can you show the measure, please?
So there, X1 was 4.9 or 5 millimeter, really. And also on the lateral, it was also quite big there. And there's a fairly shallow ampulla, 9 millimeter. Yeah, and basically either, I think it would be a 6-4 ADO2, which ends up having about a retention disc or an aortic disc of about 14, that would be. Or we go for a 10-8 ADO1.
Okay, well thank you. So why don't we open it up to the audience? You're now in the cath lab, and what would you like to put in here, or would you use a 10-8 and a 6-4? Anyone from the audience?
Yes.
So everyone's in agreement that you should use one of those 2 devices, Oliver?
I mean, just a comment, if you're going to use a 6-4, why go for a 10-8 rather than an 8-6? It seems a little bit of a mismatch in terms of the measurements, as it were. Would an 8-6 be sufficient if you're using an ADO2 6-4?
Well, yeah, hydro. Basically, I think an 8-6 might be okay. I actually wasn't here when the first angios were done. I think she weighs 20 kilos. She's got a very shallow, good ampulla. I think 10-8 is probably safer. But yes, one could probably get away with an 8-6. Yeah. But at 20 kilo, I have to say I wouldn't.
I mean, I have no problem with a 10-8, but I think if you're going for a 10-8, to me 6-4 may be a little bit too soft and could embolize.
Yeah, but there you have a much better retention disc. What? Let's have a... Yeah, anyway, anybody else? Any suggestions or comments? Changes?
Hello.
I would not.
Could you just say the...
Yahya Saliba from Beirut.
Okay, go ahead.
I would not use 6.4 ADO2 in this patient. It's a very large PDA, and the 10.8 ADO1 is more suitable, I think.
I agree.
Well, basically, what we prepared is really a guide wire loop, and effectively, we are about to load a 10.8 ADO1. It's okay.
Okay.
We can take the device now. So we put a 6 French long sheet. Okay.
Oh yeah, I can do it.
We need the device. So say 6.8.
Excuse
8.6
me.
or 10.8.
10.8.
Yeah,
Perfect.
before deciding the device size, could you do another angiogram that sheet through the PDA? So sometimes it may be more clear
Take it off.
beside the size of the device. I think 8
Let's,
by 6 is okay for this
Okay.
patient. Yeah.
Totally like this.
Yeah, so that was the angiogram before. And now Massimo has put in the
Okay. In lateral,
Chief?
we will do the angio. Lateral, please. Okay. A bit more. Yeah. Okay.
The anatomy lends itself to an ADO1 anyway.
Bit lower.
Bigger, 6.
Okay. we
So
can repeat
this
the
is
angio now.
ADO1, as probably everyone knows. This is the delivery cable, and when Massimo, or when we unpack the thing, and prepared all the dilator, the first thing Massimo did was throw this thing away, which always comes here. And neither Massimo nor myself, or probably anybody else, understands the use of this thing.
Oliver, can I just ask you, this is Elchanan, we're now doing an angiogram with the sheath across the ductors. There's really no flow in the ductors. So if it's a 6 French sheath...
Why? Well, do you want... No,
The 6 French sheath is almost completely
Sorry,
occluding the duct. So would that change the size of the device that you want to use?
It's occluded, but not completely.
Agreed, but so it's probably more like 3 millimeters maybe?
Yeah. 8 by 6. I
Can you
think
show
is okay
also
for this
that
patient.
it's not occluded?
It is occluded by
Because
the
we can also see a larger PA. Okay. Facci vedere il-
Yeah, I didn't quite, I was turned around starting with the device. Well, it is, but again, there's, even at her age, there is, I think, some slight risk of there being an element of spasm. The device is out, the device is loaded. I normally don't do an angio with the sheath across. But yes, I agree, looking at that, there's not much flow over it.
But the sheath may be distorting the anatomy of the duct as well.
Right.
Not complete.
Yes. So I think we loaded the device. As I said, there's no lateral here. Sorry. So as I initially said, the ADO2, personally I would have considered, but I think 10.8 is a safe bet. If the device wouldn't be out by or after doing this angio, I possibly would reconsider, but I think we should now progress as we are, unless there are any bigger concerns.
Oliver and the team, while you're just getting ready, if we're going to oversize a device, have you ever seen any problems of oversizing a device in a ductus? Apart from LPA stenosis, obviously, but which won't happen with an ADO1. But for instance, the recurrent laryngeal nerve, me and Joe have both seen nerve palsy when putting in an LPA stent and somehow damaging the nerve. So the question is, if you put in a very, very big device, so it gets squashed, but is it going to do any collateral damage?
Well, I personally haven't seen a recurrent laryngeal nerve injury after this. I think you can oversize a device, i.e. especially if it's a fairly long duct and you don't have a display or splaying of the PA end. it may get milked out. Okay, I think we proceed. How far are you? All right, we need the... So basically the cable is fairly long and it normally only gets interesting when you've got about 40, 50 centimeter left. You see there, even there the device isn't even in view. There it comes. And I now, well, let's get rid of all the rubbish. Yeah, it's basically keeping your hands a bit apart. And you see how much overhang there is on the delivery, on the torque view. So how far the sheath actually extends after the radio opaque marker. So now the basically engaging in no. It's basically engaging in the ampulla.
Yes.
Okay. Or is Tin in the audience? Tin, can you hear me? Or Siva Kumar? Siva?
He's coming.
Nobody.
He's coming,
what
he's coming.
did you do?
Hi, Oliver.
Hi, Oliver. I'm here.
Yeah. What would you guys use in this case? I mean, I didn't do the initial angio, but it was quite a big duct and quite a lot of volume load. The kit is weighing 20 kilo.
Yeah. In my institution,
Okay.
if I had got a very good echocardiographic image and it was measuring around 5 to 6, I would have not taken an arterial access at all. Cross the PDA, put in a sheath across and make a reflex angiogram from the back wall of the aorta. And that is not with the purpose of identifying the size of the PDA, but just to note where is the PDA in relation to the trachea on the lateral view. And then take up a device. I would have chosen possibly an 8.6 device. There's a lot of waste here.
Andrew?
Yeah, no, I agree. The initial diameter was measured as 5. Possibly we even have to recalibrate or remeasure on the pigtail catheter, how accurate that was. What?
Hi, Oliver. Tin speaking.
Yeah, Tin.
I think the device is a little bit oversized. You can, because you see the waist
Yeah.
too much, you can reduce one size is better. And thank you.
Yeah. Let's, did you do an angio?
The right.
And then we should take a pressure and stuff.
I think it's okay. It's okay, yeah. But I think an 8.6 would have been okay, but an 8.6...
Still quite a lot of flow through the damn thing. Ario? Yeah.
I think so, yeah.
Ready?
Slightly. Heavily. So an 8.6 would have been...
Yeah, it's not that particularly pretty, but I think it's fine. Is this the actual arterial trace? It's a bit damp. Huh? With contrast. Wait. Oh, you have to wet flush. Okay, that's fine. Still fairly damped, huh?
So you're going to release it?
Well, we just take a pressure, so that's the ascending aorta, or transverse arch.
Right.
There. And then pull back to descending.
Yeah, it's fine.
That's fine.
That's fine.
That's fine.
So yes, I agree, it's not particularly pretty, but rather than throw it away, I would go with that. I think it's safe. We should really do another measurement on the previous calibration of the marker pigtail, because I think that probably was overestimate, looking at it. But I think we release now, unless there are any, let's say, big concerns. You screen? Oh.
Enlarged ductuses.
Okay.
Are there any tips and tricks for how to release, in the sense of so you don't displace the PDA? Do you put tension? Do you pull? Do you push? Or is it just unscrew and hope for the best? Just tips and tricks.
But, well, normally, as I said, I would work in lateral to do this, and then it's okay. But I didn't screw the device on, and it was actually screwed on quite tight. So normally the thing is, you screw it on, you get some sort of click or feeling that it's engaged, then you do half a turn backwards. And then I normally do it on the lateral, and basically then keep just a bit of pull on the cable whilst screwing. I don't think we have to do another angio, Massimo.
Right. Yeah, I think there's a tendency also for a lot of people to pull on the device, and then when you actually release it, it sort of catapults back towards the back of the aorta. So I've never seen one actually fly out. I did that with a Grifka bag once. But I think when you unscrew, you have to really have the system just resting, as opposed to pulling or pushing.
Oh, yeah. Yes. Yes, and especially on again, I think we see that better on the lateral. You don't want to have the cable, let's say, in almost a straight line down. Absolutely. You really want to have a nice, relaxed curve within the heart.
Right.
And then as soon as the screws come undone, yeah, you have to pull the cable into the sheath so as not to catch it on any myocardium or the valves or stuff like that.
Right.
So, and yeah, personally, I'm more used to working in lateral, I have to say.
Okay. We have one comment from Bharat.
Oliver, this is Bharat. The comment I wanted to make...
Yeah, hi.
Hi. The comment I wanted to make was regarding the release. I agree that if you give tension, definitely there will be a significant recoil. But I think if you take into consideration smaller babies, their outflow tract is a little more horizontal as compared to the little grown-up babies. No matter whether you give any tug or otherwise, there would be a significant recoil in many of the cases. And that's why measuring the gradient when the device is on cable, I don't think has all that much of importance or significance than once you release it. I mean, that's what I think.
Okay,
so no, I think point taken. This on the screen then will be another pullback gradient, ascending, descending with the device released now.
Okay, well that looked good. Okay, so if you guys are done, then we'll go on with the lectures, which is on PDAs, so yes. It's very appropriate. Is there anything else you want to show us?
No. Massimo?
No. Thank you.
Okay, well, thank you very much for a great case. Thank you very much.